This is the Authority Company Podcast, conversations with leaders who are designing our future. Hola, I'm Pardavila, and my guest today is Dr. Loren Rourke. Dr. Rourke has spent more than 20 years walking alongside women through one of the hardest conversations of their lives. A board-certified breast surgeon, she blends clinical precision with honesty, empathy, and plain language that patients can hold on to when everything feels uncertain. In her new book, Real Talk, Real Hope, Breast Cancer Your Way, she brings the same voice she uses in the exam room, clear, steady, and human, to help women move from fear to informed action. Dr. Rourke, welcome to the show. How are you?
I'm great. Thank you so much for having me.
You're very welcome. And I want to start by having a bit of a level set. So I am a proud member of Generation X. And I remember growing up in the 80s and 90s when you heard about breast cancer, it was almost seen as a death sentence. And I know that therapeutics and treatments have evolved, thankfully, since then. But tell me what it's like now, here in 2026. How different is it the breast cancer treatment different from it was, 20, 30 years ago when I was growing up?
It's what I tell my patients every day. Breast cancer is a survivable disease today. It is not what it was back in the 80s at all. Our treatments have become more advanced from a surgical perspective, which is my realm, but also most importantly, what they've done with the drug regimens now. Even with more advanced disease, we're winning the fight. And so early detection is the key. That's what it's all about. Because the disease is survivable, the earlier we can catch it, the faster we can make it go away.
And, I'm not a woman, but I am aware enough that sometimes the goalposts shift on when they should get their first mammogram. And ironically, doctor, my wife is getting her mammogram done right now as we speak. I'm not kidding. She's literally at the doctor's office doing it. It's so funny that we're doing this. But tell me about that, because I know that throughout the years it has changed. And I know for some people, if there is a history in the family, they'll do it sooner than later. But tell me about the idea about when women should really be actively thinking about this.
Okay. So, I don't think breast health can start too early. But if we're talking about mammograms, it's one of the things I talk about very passionately in my book because the goalposts are shifting. The recommendations are very confusing. Many healthcare providers today don't even know what to tell women in terms of when they're supposed to be doing. So I can tell you if you look at any of the cancer societies endorsed by evidence, we all say annually starting at the age of 40. There are situations where you should start sooner, and that is if you have a young first degree relative in your family that had breast cancer younger than 40, then we'll move that, we'll shift it. And that those are specific circumstances, but I can say every year starting at the age of 40, I personally recommend a baseline at 35. I think that there is good value that comes from that. And then the other question I get all the time is when should you stop? And I say that the answer to that is as long as you're going to do something about breast cancer, if we found it, meaning you would seek a form of treatment, then I don't put an age cap on it at all because I've seen, 80-year-old women running marathons. Go for it. Get your annual mammogram because I'm pretty sure you're going to get treatment.
And indulge me, Doc. What is the pushback in terms of doing it younger? Is it just the cost benefits? Like what is some of, and you talked about like 35 for some patients. Like what is it like? Maybe if it runs in the family and a woman's really thinking about it, it weighs heavily on her. Like how early can she do it, or is there a reason for not doing it so early?
Great question. So the confusion started because of the guidelines being changed, not for any other reason other than the limitations of the mammography itself. So if you think about a mammogram is just a form of an x-ray of the breast. And when you image breast, the breast is made up of breast structures, which I talk about, in my book, in the anatomy of the breast, but that is all woven in fat. And so when you get an x-ray done, fat is black on an x-ray. The older you are as a woman, the more fatty your breast becomes. So cancer is white. Breast tissue is white. So the younger you are and the more dense your breast tissue is, you're trying to find white on white. Well, that's really hard to see. It
Ah.
show up well on imaging. So mammography has more benefit the older you are because the breasts in general become more fatty. So you're looking, like I always say, is trying to find one snowflake in a pile of snow, right? You can't see it. And so that is the reason for the confusion was the limitations of the technology, but we have other supplemental imaging we can do as well that adds to and then allows us to appropriately image the younger population.
Awesome. Thanks for explaining it. Again, someone who is not a breast carrying member, never understood that. So I appreciate you doing that.
Hey, we
Um,
even do mammograms on men. See, a lot
that's
of people
I've
don't know.
heard that. Like, tell me about that. Like, what man would need would be an active participant to need to do that.
So, 1% of all breast cancer is in men. A lot of men don't realize that they can get a lump, and if they get a lump, they need to get it checked. Most men don't even think about breast cancer when they find a lump there. They think about it as a lump, just like it would be anywhere else, right? So oftentimes they don't get checked. But the way we image, if they come in with a mass, is a mammogram. Which is why you'll see a lot of really nice dedicated breast centers, not all decked out in pink. There's a reason for that because when you bring a man in to get a mammogram, they don't really want to feel like a fish out of water, right? So it's important that we take care of them and that what they're going through because, most men, when you say we're going to get a mammogram, they look at us a little funny. But it is very helpful in imaging the tissue there just as well. So.
Awesome. Cool. Good stuff. All right. So you write and you talk about welcome to the club. No one wants to join. What does that phrase mean to you now after decades of caring for patients?
That line came to me literally in a dream at night when I was starting to think about writing the book. And the reason it resonated with me is because every patient that I've taken care of over decades now starts with, I can't believe this is happening to me. I don't want to be in this club. Nobody wants to be in this club. But I can tell you on the other end, when we get them through this whole journey, and I say, we put breast cancer in your rearview mirror. They're glad they're part of the club. They're proud they're part of the club. They have demonstrated strength. I always admire my patients because they just plow through. No matter what we throw at them, they just keep going. And it is amazing to be on the bench watching that. So the club that no one wants to join, no one wants breast cancer, but 1 in 8 women are getting breast cancer. So I say, get a book club group together, a coffee club, go to church, a women's group, start counting, someone in your group, whether it's you or someone you know or love is going to get this disease. And so that's where it came from is the club. It starts out as the club no one wants to join.
So talking to you for the last few minutes, I definitely feel the optimistic tone you have towards this and the folks that have to deal with it. How do you balance delivering hard truths while preserving that sort of hope and optimism in the consult room?
That's a tough one because I've been doing it a long time. But I always say the day I can't cry with the patient, it's time for me to retire because I'm not giving my whole self to the consult. Uh, you know, as I said in the beginning, it is a survivable disease by and large. Even the locally advanced diseases we fight. And so I tell my patients, we're about to go on a road trip. You didn't really want to go on this trip. I might be the one driving it first. My patient is always in the passenger seat next to me. I may go into the back seat at some point, and another doctor on the team's going to take the wheel. But I don't ever leave the car. I'm always with them on the journey. And although they may not like what I have to hear, I tell them I will always give it to you straight. I won't hide anything from you because if I'm keeping all my cards tucked in and they don't know, how can they plan? How can they make decisions? So I always tell them, I'm going to give it to you straight, even if you don't want to hear it. I will also tell you the truth when we need to talk about things you don't want to talk about. But I'm here. I'm not running away. I'm not leaving you. Thankfully, I don't have to give, really bad news that often because I'm on the surgical end of things. But I'm prepared to do that. And I've done it many times before when patients come to me and say, I can't get a straight answer. I will give it to them. And so that is a bond we create at that first visit that I tell them everything because if it was me, I would want to know because I have decisions. Everyone's life is different, everyone's circumstances are different. So I think that we owe them, it's their right to know, and we owe them to provide the guidance they need to make those decisions.
You talked about the moment you tell these patients that they're part of this club that no one wants to be a part of. But what do you think the patients need most in the first 24 hours after that diagnosis? Because I think for many, it's probably like dread. Even though we know that there's advancements in this, when that C word gets thrown around, you're automatically thinking doom. So tell me about those first 24 hours.
So, I think that's why I wrote the book. the book is really designed for that first 24 hours when you haven't gotten to anybody yet that's a resource or an expert in this. And what do you have? You have social media, which is just propagating a lot of false information. You've got blogs out there dispensing who knows what. And so what you need in that moment is you got to calm the noise, because when people hear cancer, the world stops turning. And so people will ask me, why don't you see someone the same day they get their diagnosis? And I say, they won't hear anything that I say. They're not ready to hear anything. They have to process that word. And so I designed the book to be a curl up on the couch with a blanket and a black box of Kleenex. And I'm going to be there with you, but in the comfort of your own home, where you can start processing. And I always say, you need to take it one step at a time. You need to get some sleep. You need to know that the world and the sky is not falling. And I break it apart piece by piece. Now, when they come see me, I start at the very beginning. You say, what do they need in that first 24 hours? Well, they need someone to say, I've got this. This is what you need to do. If you feel the urge to Google, because everyone wants Dr. Google, right? If you feel the urge to do that, stop. Read something that you know is full of truth and hope and will give you a step by step, so that when you come into the doctor's office, you've got your list of questions, you know what to ask, and you become your own advocate. And you start assembling that inner circle, the social circle you need, whether it's a spouse, a partner, a friend, and you get that circle solid and small. Because if it gets too big, the chatter then paralyzes you from making decisions.
Talk about Dr. Google, because I've done many health podcasts with doctors, and they've been grappling with Dr. Google for decades. And I feel a lot of them, have openly said to me, like, at first, it sucked. Like, it really sucked that this was part of their life now. But many who've been doing it for a long time, they now accept it. They know that that's part of the fight they have to fight in terms of the healthcare journey that their patients are going to go on. So tell me about the emotional damage you see when fear is fueled by this misinformation provided by the aforementioned Dr. Google, and of course now by many a TikTok feed and Instagram feed.
Oh yes, now it's I think it's even more um, dangerous for patients now than ever before, because there's more misinformation. I say I joked about Dr. Google, right? But at the same time, you can use Google as your friend. And so that's when I said, you're looking for certain um, credentials for an imaging center, certain accreditations. You want your medical team to belong to certain societies. Google's great for that. It really does. So you just need someone to steer you on how to use Google to your advantage. I think with the Instagram, the TikTok, the blogs, I'm finding the little Facebook pages, those are almost the worst, because everyone has their anecdotal story there. And those are dangerous when you start following those. I think it's also become a platform for unproven treatments. It really concerns me, the amount of financial scams that are out there taking people's money, and they're using hope to do it. And that's just a crime. I mean, you're taking someone in their most vulnerable moment, where they'll cling to anything that they can get their hands on. And so that's why we have to ground in fact and truth. And I always tell every patient, like my book says, we're doing it your way. You are the decision maker. It's our job in the clinical team to give you your choices, your options, and then you decide. I always tell a patient, I'm not going to fire you if you don't do what I tell you to do. I will still be there with you, and I will still go through this with you. And I will again remind you of what the recommendations are, but the patient gets to make the choice.
Yeah, great. Let's talk about timelines here, and I know, and we'll speak broadly because I know everyone is different. But give me an idea in terms of the timeline of their journey from diagnosis to how long the treatment takes. Because in the book, you write about the fact that breast cancer is rarely an emergency. Like, when they identify, it's not something that is going to affect them the next day or even a week or two later. So how does slowing down shift a patient's mindset? And explain to me in terms of, like, so if it's not an emergency, it has to be done, like, the biopsies and treatments and things have to be done right away. Tell me about how long the life cycle of that treatment usually takes.
Okay, it depends on the extent of the disease, obviously. When I say it's not an emergency, what I mean is, back to when I said, if they found out today, would I see them today? Not a good plan. It's not going to be a productive visit. I try to get patients in ideally within 48 hours if I can from the time they got diagnosed. When I say it's not an emergency, what I mean is the first definitive treatment. So seeing me is important. Getting into me sooner rather than later is important because I need to de-escalate. I need to answer questions. I need to make sure they know when I say, I've got you, let me worry about this and you go do your life. Because women are busy. We are really busy, juggling a lot of things. And then you pile this on top and it's just enough to push them right over the edge. So I say, you let me worry about this. But it's not, we don't have to do surgery tomorrow. In most cases, the cancer gives us enough time to get our treatment team together, to pick a surgery date that works. Now, I always tell patients this is not the time to go on a 6-month cruise. Okay, get rid of that. But if you have a bucket list concert on your schedule in 2 weeks, then go. We will time it afterwards. I also think it's important, especially when we're talking about surgery, that a woman makes the correct choice. So almost every woman comes in and says, I want a bilateral mastectomy. And I spend a lot of time talking people back off that ledge because in the United States right now, that is the social media craze. Everybody wants a bilateral mastectomy. They
So
think,
let me jump in there, doctor. The bilateral mastectomy is when you guys are removing both breasts? Okay.
yeah. And everyone comes in with fear driving that, and they say, this is what I want. And so I have to get people to calm down a minute, listen to reason. Let's talk about the pros and cons, and then let's make a choice. The problem is, once I do a mastectomy, I can't undo that, right? So I say you need to take some time, not sitting here with me, not feeling pressured being in a doctor's office. You need to go home, you need to sleep, you need to have pillow talk with whomever is in your circle. You need to think about how you really feel. You need to get in the shower and say, okay, what is my relationship with my breasts? You need to go through all of that. That takes a little time to process. So going to the operating room the day after you see your surgeon is not a good plan because you're not going to choose the right thing long term. And so that's why I say it's not an emergency. Take a breath. If we do your surgery in 4 weeks, you're going to be okay. There are certain diseases within breast cancer, certain forms of breast cancer that move at a more rapid pace. If that's the case, we recognize and have that conversation early on. But most of the time is your friend to get your head together. And I always say when I walk in the pre-op area on the day I'm doing surgery, I can see the look in a woman's eye now and I know if they're ready. If they're having tears, that doesn't mean they're not ready. That means they understand. But the look of that, I'm ready, let's go, I'm good with my decision, then I know we're ready to go.
And the bilateral mastectomy, I know it became very trendy. I know a lot of celebrities openly talked about it and probably fueled this interest in people doing it. Can you just, without going into all the alternatives, what is the common alternative to the bilateral mastectomy?
It's breast conservation. It's what we call a lumpectomy. It's getting the cancer removed. The survival is equal between lumpectomy and a mastectomy. Women often want to argue with me about that, but the data is proven. Breast conservation is a very good choice. If the cancer allows it and your surgeon says it's on the table, trust it. We're giving you an equal. Survival is equal. And so that is the alternative. And then you asked me before about, what's the life cycle of this?
Yeah.
If you're talking about all treatment modalities, meaning we have to do everything, then the cycle is about a year, and then oftentimes you're taking a pill for another 4 years or so after that. But most people talk about the big treatment guns as being confined to 1 year. If you get a really favorable early breast cancer, we can knock that out sometimes in just a matter of 8 weeks or so.
Wow.
So, but I tell most patients, even if you get on that lucky end of the spectrum, just plan a year because breast cancer, it's physical and it's psychological. And it takes a little while to transition from accepting the diagnosis, getting through the acute treatment plan, and then settling into what new normal looks like. And so I say, it's a year's journey for most, sometimes a little longer than that, but a year is a safe bet.
That's great. Thank you for sharing that. And I wonder, you talked about the fact that after that 1 year cycle is done, they have 4 years of medication to take. And I know there is this sort of general feeling of anti-pharmaceuticals in this world. And I, selfishly myself, like I'm now questioning every time, like, do I even need to take this? Like, is it necessary for me to take this painkiller when I'm not really in that much pain, right? So tell me about the idea behind the medication that supports the after treatment.
Okay. So those medicines are most commonly referred to as hormone blockers. So if you have a breast cancer that's driven by estrogen or progesterone, then giving you a blockade from those hormones essentially starves any residual breast cancer cells that might be harboring about. We don't want them to cause trouble, right? I always say they might be a little car riding around the highway. We don't want it to find a parking garage, right? We want to kill it before it ever gets there. So it's hormone blockers, and it's not that is very targeted treatment, right? Those are directed specifically at cells that need those hormones. Women don't particularly like this medication. Why? Because it tends to mimic menopausal symptoms. So there, I always, if the woman brings her partner or spouse in there, I'm the first one to go, okay, blame us for the moodiness and all the things that come with that. It's us. We're the ones giving her the medicine that's making her act this way. But they're very powerful. So people often dismiss these little pills, but they are life saving in breast cancer. So it is really, really important. So I think of when you talked about, should I take a Tylenol? Should I take an ibuprofen if I have a headache? That's more optional. This one, not so much. And so I tell the patients, you got to at least try for me. Don't say no without trying. That's kind of my motto with, when I'm working with these women through this journey, because they say, I don't like the side effects, but you haven't tried it yet. Well, you might be one of those women that doesn't have side effects. And if so, then great, then you'll get through that 5-year course or 10-year course. You'll be okay. So I think it's just important that we take each medication. What is it designed to do? What are the risks and benefits? And then give it a try.
Good stuff. All right, so I know part of your book is this mission, but like, what do you wish every newly diagnosed woman understood about survival rates and the treatment? Like, what is one thing that you'd like them? They'll probably get it from the book, but during this conversation, I'd love to know, like, what do you want them to know about survival rates? Because we started this conversation talking about how things have changed since I was a kid, and the survival rates have increased. Tell me about how specific, how broad you speak to these patients when it comes to survival rates.
So when they're with me on the first visit, I mean, I break down the stages right out of the gate because it's a couple questions that when women come in on that first visit, they want to ask, but they don't necessarily know if they want to ask. So one of them is, what stage am I? How bad is this? And I give it to them straight, right out of the gate. What are we thinking today? What more information do I need to know in order to get that narrowed down to something more precise? So that's the first thing. Early stage breast cancer is a survivable disease. That's why I say you're going to beat this. You are absolutely going to beat this. So I focus them on that. You are going to beat this. So don't delay, don't ignore. Because the more that you let breast cancer do its own thing and run rogue, then your survival rate goes down. Now, if you have stage 4 breast cancer that has spread beyond the breast and the lymph nodes and has now gone elsewhere, what we call distant disease, that disease is not necessarily curable. Then we're buying time. We're buying quality time. Anything less than a stage 4, we are going for a cure. The earlier the stage, the easier the cure is to get. So don't sit at home in denial if you have a lump, because the bigger it gets, the harder it is to fight. So I say, get it when it's early. Put it in your rearview mirror, go back to your life. That's it. You're done. You're one of the 8 and you are now rallying. You got the t-shirt. You can go on about your life and, celebrate thriving and having survived breast cancer. So for me, like I always say, anything less than stage 4, we are going for a cure.
All right, excuse me for this stupid question, but I understand that there's stages of cancer, and you mentioned the fact that stage 4 is the worst. Even I know that. Do people start at stage 4, or does it work its way up the chain? Tell me the idea, because I know sometimes people throw these stages around and they're like, wait, so did they start at a level? Did they start at 1 and then get to 3? Did they start at 3 and get to 4? So please indulge me here.
I love that you asked this because it is a common misconception. And it's funny when you get breast cancer, everyone says, what stage is it? The number doesn't mean anything to them either, but no one knows what else to ask. Right? What else are we supposed to say? So, stage 4 is metastatic breast cancer. That is disease that has spread far and wide. I give the example: colon cancer's gone to the liver, breast that's gone to the bone, prostate that's gone to the bone. This is cancer that has left the building. Okay. It is no longer where it started. So, very few patients are diagnosed as stage 4. So, to answer your question, that's cancer that's been brewing a while. Okay. Most patients come in at a 1 or a 2. where early detection on a one, most of the time, it's not even a lump we can feel. It's something they caught on a mammogram, which is why they need to go get a mammogram. We can get rid of this before it was ever anything anyone could feel, right? Stage 3 is a more advanced cancer. That's when it spread to the lymph nodes. We've got a bigger problem that we now have to get. I say we're going to have to arm a bigger team. We're going to have to use our arsenal to make this one go away. So ideally, we want to catch it earlier, a 1 or a 2, where we don't have to whip out our entire arsenal to try to make it go away. Does that
Oh,
help?
that's great. No, thank you very much. Like I said, I'm not a very bright man, but I appreciate you speaking to me plainly, not making me feel like an idiot asking these questions. So thank you so
No,
much.
it's a question everyone asks, so I'm glad you asked it.
Good, good, good. All right. So we can't not talk about this, but the intersection of mental health and breast cancer. Because again, I hate to be keep harping about my age, but like 30 years ago, nobody cared about anyone's mental health when it came to breast cancer or cancer, period. We've all evolved as a race, and we understand that the mental health and the physical health are very much intertwined. So tell me about why mental health is so inseparable from medical care that you are providing.
Well, it's kind of simple. I, I say, think about breast cancer and stand in the line at the grocery store. All the magazine covers. You can't get away from this. It is front and center. Whether it's swimsuit models, the red carpet in Hollywood, for women, like it or not, and social media hasn't helped, this is part of a woman's essence and it's in your face all the time. So unlike I often use colon cancer as an example. It's hiding inside. We can sneak in there and take out a piece of a colon, and most patients are never the wiser, right? They're like, "This is great. I still look fine. I might have a little zipper, but I'm good." For women, this is a game changer psychologically and as part of their mental health. So to ignore that when you're treating someone with breast cancer, you are not going to form the bond you need with your patient because the first thing they come in, they're scared. Social media has told them they need to cut them both off. That may not be necessary, right? So now their head's spinning because they're like, what am I going to look like? Am I going to look like a monster? Am I going to look like Frankenstein? They worry for themselves, all the social dynamics. If they have a partner or a spouse, is that person going to view them the same? If they're single, are they ever going to find someone again? All these emotions enter into that consult visit. So I always say, you shouldn't be punished if you get breast cancer. And back in the day, 30 years ago, when we did surgery, nobody cared what a woman looked like on the other side. And I trained in that era. And it is terrifying to think. Nobody thought about reconstruction. If we had to do a mastectomy, we just did. We left women with a big old scar, told them they could go wear a prosthetic. It would be fine. It used to fall out of the bathing suit when they were, no one gave any thought to a woman's body image. Now, thankfully, we have caught up. And now I say the cancer's here. It is always here. But what you look like is right here for me. And even though I get the occasional patient who says, well, I don't care, just cure me of this. I'm going to say, you're going to care in 5 years. You're very much going to care what you look like when you're not thinking about breast cancer every day. So I'm thankful. We've done an amazing job, but that's where I have to, in a relatively short amount of time, get to know a woman on a pretty private level because I have to talk to them about these things. What do you think about your nipples? All these things. You can never make assumptions. I've had a 30-year-old woman tell me she didn't want reconstruction and wanted to go flat. I've had an 80-year-old woman beg me for an implant. You can never judge or assume that you know that the woman sitting across from you, what they're thinking or what their life story is. And so I have not a lot of time to get close to them, get them to trust me, and then we have these real conversations about what it is they're looking for. If we can make something better, why not, right? And we often do. I have women who come out on the other side of breast cancer are happier with the way they look than they were before. So I think that's a win-win, and that adds to the mental health and the mental wellness of the whole process.
That's great. We talked about how like Dr. Google and social media is like lying to people about treatments and such. But something you write about in the book is also the common myths about prevention. So this is something I don't really know much about, but like, is breast cancer preventable? Tell me about. Well, let's talk about some of the myths and then go into like, is it preventable? Are there treatments that can help you stop it from getting to even stage 1 or 2?
Okay, well, first of all, please don't beat yourself up. You shouldn't be an expert on breast cancer prevention. Okay, so I'm gonna cut you some slack.
Thank you.
But, so I always say the biggest risk factors for getting breast cancer, data shows it over and over again. One is being a woman, and two is getting older. We can't do anything about either of those. Okay. Those are the two biggest risk factors. If you're talking about general population, not people that have a genetic mutation or a very alarming family history, you're just talking general population. 12 to 13% get breast cancer. So what do those people do to try to prevent it? Well, I always say, taking a lot of hormones, that's always been controversial, but I've never seen, for example, a woman decline IVF for breast cancer risk, right? If you want to have a child, you're going to do what you're going to do, or if you don't want to have children, you're not. So when it comes to things you can do something about, the one that we're now harping on most strongly is there is a definite correlation with how well you do with your fitness level. So if you have a high BMI and you are obese, we have now shown your breast cancer outcome will not be as good. So fitness is a big deal, and do it while you can, because I can say, talk to any postmenopausal woman about trying to lose weight. It's hard. It is really hard. So this is where I said breast health can never start too young. Start when you're younger. Get your plan in place. Good diet, healthy diet, regular exercise. These things keep your BMI in check. And then your overall fitness is good. So God forbid you get breast cancer, you're not going to have to now face for example, 100-pound weight loss on top of everything else you're trying to navigate. The other thing is people ask me all the time, well, is it okay to drink? I say, this is the thing, everything in moderation. I am not asking you to give up the vice you have of a lifetime. That's ridiculous. And the thing is, it won't stick, right? If you ask people to do things that are now their quality of life is bad, well, then don't do that. So I say everything in moderation, take good care of your body because that will pay it forward. And my patients that come to me with breast cancer and they're really fit, and they say, why did this happen to me? I say, well, we don't know why it happened to you, but all that goodness that you poured into yourself is now going to pay it forward because breast cancer treatment is going to be easier for you and your outcome's going to be better.
That's good. I just came to me because I remember growing up and like every TV movie about a woman having breast cancer was like a mom. Like it was always like a 30-ish blonde woman straight out of central casting. And that's the image of like who I see gets breast cancer. And you talked about how these ages vary. How much do they vary in terms of women that do get breast cancer? Is it beyond my small mind of it's only like a mom in her 30s who lives in the suburbs? Like, tell me about the age range of your patients.
Okay, so 30s is young to get breast cancer. Why
Okay.
that in the movies is because it has a big effect, right? The young mom trying to juggle kids and then deal with this. Most women are over the age of 50, okay? But we are seeing it in younger women, but it's because our early detection's better than it's ever been, right? And the awareness is there. And now we catch things much earlier. So I would say, yes, most of my patients are older, although I use that gently now that I'm getting older. Let's just be careful with these labels. But I would say, 30s is considered young, even 40s is still considered young. And so we are definitely making sure there's not a genetic component when we see these. And then 20s, extremely young and rare.
Okay, cool. So what has breast cancer taught you about resilience in the women that you treat? Because obviously you've had an effect on these women, but these women have had an effect on you as well. Tell me about the idea of learning about resilience from these women.
I learn from my patients every single day, literally something, um, because they go through it with style. And I say that truly. They embrace the things that are hard. The hair loss with chemo, nobody wants that. And yet, you think in your mind they're going to run off and get a wig and hide it from everybody. No, they, embrace that bald head and they might wear a scarf and they do it with style. They find humor, they find strength in places they never knew they had. And I always reminds me every day to be grateful, be thankful for your blessings because these women do things that I look every day and go, wow, what if I'm a breast cancer surgeon, right? So I think about it. What if this happened to me today? What would I do? And I'm more ready for it in terms of my daily logistics and life than any other woman is, right? But they do it with style. They do it with grace. They're brave. They're strong and they form a bond with their inner circle that stays for a lifetime. And I can tell you, my patients that have participated in events, and there's a strength there in numbers. It's that club no one wants to join, but that club is strong. And so it's amazing. I'm so lucky to take care of these women every day because, like I said, they teach me every day.
Awesome. And lastly, Loren, I always wrap up these conversations, takes folks behind the dedication of the book. And you dedicate it to my mom. You'll always be my biggest fan, role model, and best friend. Why was it so important to dedicate your book to Mama?
Uh, well, I wouldn't have written it without her. Um, I'm an only child, so she was my everything. Um, Actually, her anniversary of her passing is tomorrow. So, I when I look at the story that my mom went through, and I told it at the end of the book, of course, and no one really sees that one coming. My patients, I don't really talk about it much, but it's made me the doctor that I am. And so people always ask me, well, did you go into breast cancer because of your mom? No, for some reason, I became a breast cancer surgeon for my mom, right? So that she, one day, who knows, she would need, me to know something about the disease and to walk through it as her daughter. Um, it's a gift. I gave it to her because I never forget her journey. I think about it every day. And I think in her way, she was like, you are going to give this forward. You are going to take my journey and use it to help other women. And so I do. And so there was no one else I would dedicate that book to. I wouldn't have written it if it hadn't been for her voice inside me. So, yeah.
The book is Real Talk, Real Hope, Breast Cancer Your Way. She is Dr. Loren Rourke. Loren, thanks so much for the time. I really appreciate it.
You're very welcome.
And that's going to do it for this episode. If you want to find out more information about Dr. Rourke and her other amazing authors, go to theauthoritycompany.com.